47-year-old. He presented in November 2021 with a 1-month history of a left-sided testicular mass. He'd been HIV positive since 2018, on ARV since 2020, and was virally suppressed on TLD. He had no B symptoms, just this painless left testicular swelling, about 9 by 8 centimeters. He was ECOG performance status 1. And his investigations, his CD4 count was 179 with an undetectable viral load, LDH of 230. Everything else was fine. And in fact, when we saw the staging PET CT, we were quite surprised because he had a lot more disease than we expected clinically. And so he had stage 4 disease. He had lots of bony involvement, some lymph nodes, and bilateral testicular involvement. His IPI score was 3, which put him in a high intermediate group, and using the NCCN IPI was also in the high intermediate group. So this is his staging PET CT, and you can see the bony involvement. Here's rib involvement. There's involvement of the femurs. He's got testicular involvement, bilateral testicular involvement. So we plan to treat him with 6 cycles of CHOP and prophylactic high-dose methotrexate, 2 cycles. We did an interim PET CT after 4 cycles of CHOP, and he had a complete metabolic response. We completed 6 cycles of CHOP and then wanted to admit him for methotrexate. But you know, patients, when they're feeling fine, they don't actually want to come into hospital. So there was quite a delay before we received the first dose, and he decided not to come for the second dose. And I actually phoned him about 2 weeks ago just to find out how he's doing when I was preparing this talk. And he's actually well. So I just wanted to show you his CT, his PET CT. This was at staging, and you can see all these bony lesions here. And this was after, I think it was 5 cycles of CHOP. Had a complete metabolic response. There's something interesting about this PET CT, and I don't know if we give prizes in this talk, but if anyone can figure out what is different about this patient, yeah, let me know. So the next case is a very sad case, and this is the case that Jessica is going to demonstrate the bone marrow findings of. This gentleman presented in February of 2019 with a 3-month history of not only swelling of the right side of the face, but also of the left orbit, the left side of the abdomen. He lost a lot of weight. He had night sweats. He'd been HIV positive since 2015 or 2016, was virally suppressed on the fixed dose therapy, had no comorbidities. He had not even had tuberculosis before. He was previously well, but he came in really ill. He was an ECOG performance status 3 to 4, very weak, wasted, clubbed. He had lymphadenopathy, and he had this right-sided neck mass extending from the parotid to the submandibular region with trismus, right-sided ptosis, left-sided abdominal swelling. CD4 count was 343. LDH was quite high. And yeah, everything else was fine. We did a lumbar puncture, and there were no malignant cells in the CSF. But on bone marrow biopsy, he had 65% tumor burden. His heart was fine. On CT body, there was extensive bone and nodal disease, hepatosplenomegaly, a left retroperitoneal or renal mass, and also lung nodules suspicious for TB. We sent sputum away, but there was nothing. There was no TB wasn't proven on the sputum. The CT brain had multiple bone lesions. Also scalp, epidural, dural, and extraconal orbital soft tissue masses, and the bilateral submandibular and parotid nodes were visible on that scan as well. So he had stage 4 disease, and looking at the IPI, it was 4 out of 5, high risk, and the NCCN IPI put him at a high intermediate. And the only reason it was high intermediate is because he was young. Otherwise, you know, it might have been more. We planned for CHOP, 6 to 8 cycles, and prophylactic high-dose methotrexate ×2. So he got his first cycle of CHOP on the 13th of February of 2019, and he actually did surprisingly well. He improved clinically, the right facial mass resolved, he started gaining weight. He still had left-sided cervical nodes that didn't seem to disappear. We did a CT after the 5th cycle, and the retroperitoneal mass had nearly resolved. There was no splenomegaly, but the lung nodules were progressive. And then we looked back and we realized that actually the sputum that we sent off in February came back culture positive, and we weren't aware of that. So yeah, rat over the knuckles, because that was really a bad thing to miss. But we sent him for TB treatment, to commence TB treatment. And a week later, he had his 6th cycle of CHOP, but we booked a CT head because we needed to see what was going on with the disease in the head as well. And then he came back 2 weeks later because the right cervical mass, which had completely resolved, now suddenly started growing rapidly. We did a biopsy, and hopefully Darshini will show us that biopsy. And then came back again, I think about 2 weeks later, well, a week later, very unwell constitutional symptoms, tachycardia. The mass had enlarged in size. We gave him some palliative chemo. We planned for some palliative radiotherapy. We referred to hospice. Then he came back 2 weeks later with confusion. By then we had the CT brain. It actually showed, curiously, that the intracranial soft tissue masses that had resolved completely, but now he had leptomeningeal enhancement, which they thought might be either infectious or disease. On the LP, there was no evidence of infection, but he had atypical cells. And we wanted to give him intrathecal chemo, but he declined. He improved a little bit on steroids. Then he was then on palliative chemo. We just gave a little bit of cyclomethotrexate and zinc, and gave some palliative radiotherapy to the right neck. But as soon as we finished on that side, he developed new masses on the left side, and then came back a week later with generalized weakness, being unable to walk for a week, and features of spinal cord compression. And we admitted him just for TLC, and he died on the 1st of September 2019. So yeah, thank you. That's the
Thank you, Zainab. That's those are 3 very different, interesting cases. And thank you for sticking to time. We've got some responses to your quiz on the PET scan. I'm not sure if Jacques and Sophia want to give their responses. In the chat, Jacques has written single kidney, question mark.
Yeah, I thought it looked like there was only 1 kidney. Just on the brief view we had, I thought, but yeah.
Only 1 kidney, and they say that he had, okay, well, we can't see it, but I thought that was curious. He has 13 pairs of ribs.
Oh,
and
goodness.
okay.
Kidney.
Yeah.
Okay, very interesting. We didn't have time to count the ribs, but yeah, the kidney was quite, we could see that. Thank you. So I'm going to share my screen now. Just give me a minute. Okay, so I'm going to be talking about the hematology diagnostic approach to plasmablastic lymphoma, and I'll be using the last case that Zainab mentioned. So this patient didn't really have anything that stood out on his FBC. He had an anemia, which is very common in HIV patients, as you know, very non-specific, with a reduced reticulocyte production index, indicating poor bone marrow response. The LDH that I had was a bit lower than the one Zainab mentioned, so it did start up above 1,000, and he had a slightly raised uric acid, and there were no suspicious plasma cells or lymphoma cells on his blood smear. It was just a bit left shifted. However, on the bone marrow aspirate, this was very abnormal, and you can see these very large cells. I mean, this is a normal neutrophil over here. These really are some giant cells. The marrow was hypercellular and had these numerous plasmablasts with eccentric nuclei, a prominent Golgi or perinuclear Hoff, More dispersed chromatin and with more frequent nuclear, well, you shouldn't normally see nucleoli in a mature plasma cell. So these are much more immature than a normal plasma cell. And then there were also some immunoblasts, very large. This is a nucleated red cell. So you can make out how really big these cells are. And then the cytoplasmic fragments in the background. So the first thing we did after seeing the bone marrow aspirate was to run flow cytometry, and we used the Euroflow diagnostic approach. And in this particular setting, we were looking at a bone marrow plasmacytic abnormality. So we went ahead and did the plasma cell dyscrasia panel. And just to point out what the principles of that is according to Euroflow, and this is from the article by Alberto Orfeo, who's the god of Euroflow, Spanish. We use a 2-tube 12-marker combination, and the panel of markers aims firstly to identify plasma cells, to discriminate normal and aberrant plasma cell populations, and importantly, to note that no single marker can differentiate normal from malignant cells. So we need at least 2 aberrant markers and or cytoplasmic light chain expression. And we also want to characterize cell surface markers that contribute to defining prognosis. So this would apply to plasmablastic lymphoma and to myeloma. It would also apply to MRD detection in patients who've been treated previously for a plasma cell disorder. So our particular patient on the FAPS Cantor, we identified the cells according to CD38 and 138 expression. And you can see they were 45 positive. They had aberrant expression of CD56, this dual CD138 and 56 expression. There is markedly increased kappa, so they stained positive for cytoplasmic kappa compared to lambda. So they were clonal with very high bright beta-2 microglobulin. On the second tube, we can see here that the CD117 is aberrantly expressed and CD28 is also abnormally expressed. So there are more than 2 abnormal markers, and we have cytoplasmic kappa expression. And that is a summary of the immunophenotype, and we found about 10% clonal CD38 plasma type cells on the flow. On the bone marrow trephine biopsy, it was really very heavily infiltrated with these sheets of immature, large plasmablasts. They did have the eccentric nuclei and often the coarse clock face chromatin. There were also some multinucleate forms, some abnormal mitotic figures, and I'm sure Darshini will show some more photographs from the tissue for the histology. This is the MUM1, which is a plasma cell marker, which came up beautifully in the nucleus, and Ki67, which is a marker of proliferation, is very high. I'd be interested to know what Darshini said, but on the bone marrow trephine, I would say it's more than 80%. So a high Ki67 of above 80% is very supportive of a diagnosis of plasmablastic lymphoma, as opposed to anaplastic plasmacytoma or myeloma, where you would expect a lower proliferation index of less than 80%. And very importantly and strikingly, the EBA-ish was strongly positive in the nuclei of these plasma cells, so confirming that the tumor cells are actually EBV infected. Sorry, there's something happened with the table. So this table, this is a table that my colleague Janique actually compiled for a recent article that we wrote for the International Journal of Laboratory Hematology. And what she did was she looked at 3 publications between 2005 and 2021, and the numbers of patients tested for each of the various markers. and looked at what proportion of them were positive. So it's important to look at the overall panel of markers, and I just highlighted here the ones that are really sort of stand out, as we said, the CD38 and 138, and importantly, CD20 is typically negative as opposed to other lymphomas. The EBA-ish is positive in around 70%. There are some other series I came across which reported higher positivity of around 80%. HHV8 is consistently negative. The MUM1 is very, positive in virtually all cases, and MYC as well is very important because that is positive in at least usually around 43%, again, some reporting even higher. And of course, the big question and the big elephant in the room when we deal with these cases is, are we looking at a plasmablastic lymphoma? Are we looking at a plasmacytoma with plasmablastic or anaplastic morphology? And that can be very difficult to differentiate because they can really have identical morphology and immunophenotype, but the additional markers such as EBA and MYC are very helpful. So all of these have 38, 138 and MUM1 positive. Plasmablastic myeloma can have cyclin D1 positivity on staining due to the 1114 translocation. In plasmablastic lymphoma, as we've said, they're usually EBV positive, and there are, in that particular subgroup, they have a high incidence of MYC and CD30 positivity, and this pattern is very rare in plasmablastic or plasmacytoma or plasmablastic myeloma. Of course, with plasmablastic myeloma, we need to look at all the clinical, the radiological features, all the other laboratory findings. So looking at the paraprotein, serum free light chain ratio, lytic bone lesions, and again, specifically excluding EBV30 and MYC. Just to mention some of the other lymphomas with plasmablastic differentiation, ALK-positive large B-cell lymphoma can cause diagnostic challenges because it has a plasma cell immunophenotype, but it is ALK positive and importantly, frequently associated with the 217 translocation, very rarely the 25, as in ALK positive diffuse large B. Then in terms of the others, I've just highlighted here for HHV8, that's usually fairly straightforward because we can stain for HHV8, and immunoblastic diffuse large B has pan B-cell markers, and EBV positive diffuse large B would have also pan B-cell markers and EBV positivity. So that is it's a helpful way to try and differentiate these lymphomas. There have been various diagnostic algorithms proposed to try and more easily differentiate plasmablastic myeloma from plasmablastic lymphoma, and most recently there was one published last year where they used EBA negativity, a Ki67 of less than 80%, and a serum free light chain ratio of greater than 100 to support a diagnosis of plasmablastic myeloma. But there are some cases, and the WHO does acknowledge this, that there really is some overlap, and that in fact a distinct definite distinction cannot be made between plasmablastic myeloma and anaplastic plasmacytoma. In terms of the genetics, there's a lot of work and research that is happening in this area. Our colleague Pascal Willem has been very active in this area. From VITS. We know that if there are samples that are suitable for karyotyping, the karyotype is typically complex, so has many abnormalities, usually with an associated MYC translocation. If we do FISH, that is usually quite helpful in picking up these MYC translocations and amplifications. And in contrast to myeloma, the usual partner in plasmablastic is to the immunoglobulin heavy chain on chromosome 14. Whereas in myeloma, that is very, very unusual. It has many other partners, but not to the not the 8-14. So 14, usually 14 can translocate with 6 and 20 and 14, but not 8-14. So this leads to an overexpression of c-MYC on the immunohistochemical stains, and they use a cutoff of 40% to demonstrate positivity on the staining. And in terms of this high prevalence of MYC rearrangements, as I've said already, it's more prevalent in the EBV positive cases. There was a recent series which used targeted NGS with a lymphoma panel and identified MYC mutations in almost 70%. And of those, so 16 out of 23 cases had MYC mutations on NGS, and 14 out of 23 had MYC translocations detected by FISH break-apart probes. So I think that's quite reassuring. It shows that although we don't have NGS at the moment to analyze these cases, we can actually pick up the majority of them that do have MYC mutations on FISH. And yeah, there's a lot of work going on in this area, and Janique will address this further. I just wanted to quickly mention HIV-associated MGUS, because I think a lot of the diagnostic challenge with plasmablastic lymphoma can be when they have monoclonal proteins. And I thought I just looked up in the literature to see how many HIV patients have monoclonal proteins, and it's actually quite high. So HIV patients are often diagnosed at a younger age with monoclonal proteins, and they often disappear with ART. They are typically fairly small, so up to 6 grams. And for example, in this particular series of 25 patients, they monitored them from diagnosis, and after 21 months, 7 had presented with malignancy, but 9 actually had, the protein had reduced and gone down to 0.5 after receiving antiretroviral therapy. And in another Italian study, there were almost 2,000 patients newly diagnosed with HIV, also young. They only included those who had SPEP positive on more than 2 occasions, and they found a prevalence of 4.5%, quite small, again, IG, and usually IgG, but only of around 1, and kappa more than lambda. So I think that's quite interesting. It'd be very interesting to know in our patients how many of our HIV patients do have monoclonal proteins, because I think it adds to the diagnostic challenge in these patients. So I'm going to stop there, and I'd like to, I'm not sure if there are any questions or comments at this stage, or if we should move on to Darshini's presentation.
Hi, Jessica. Hi, Zainab. Thank you for the opportunity to participate, and just to give a little overview of the pathology side. I'm sorry, I just want to try to see if I can find it. Here we go. And is this okay? Can you see the slides?
Yes.
I can see the slides. Thank you very much. Go ahead.
I'm going to quickly overview the pathology of plasmablastic lymphoma. It's, as Zainab and Jessica have mentioned, it's aggressive lymphoma with an unfavorable prognosis. The WHO 2017 Blue Book on Lymphoma actually does classify it according to a distinct entity, predominantly found on extranodal sites. It's interesting that they say it's most commonly found in the oral cavity, but in our lab, we've been finding that we are seeing a lot of plasmablastic lymphoma in the GIT, specifically lower GIT, as in the stomach, gastric, duodenal as well as rectal. So that's a very interesting finding from our side, especially with HIV concurrence as well. It requires specific histology, immunophenotyping, and clinical correlation for definitive diagnosis. And it's been described as monomorphic sheets of intermediate to large cells with the plasmablastic or immunoblastic features, right? Like I mentioned, it's a subtype of diffuse large B-cell lymphoma with sufficient distinctive features that make it a distinct entity. Usually occurs with immunosuppression, HIV infection, even iatrogenic immunosuppression, and even can be seen in the elderly. The median age range was usually men of about 50 years. The other sites that I've mentioned in terms of involvement would include skin, gastrointestinal tract, and the bone. But again, nodal involvement is also seen, especially in post-transplant cases. And so we have to be aware of this because Kritoskir has a very big renal as well as lung transplant unit. And so we always have to be on the lookout for post-lymphoproliferative disorders that are EBV associated. Okay, so in terms of the pathophysiology, which Janique will elucidate a little bit further on, I just want to mention that it's derived from the post-germinal center B cell or the plasmablast. EBV is observed in at least about 75% of cases. Remember, plasmablastic lymphoma can be EBV negative, so it's not always the clincher to the diagnosis. And then so that's why you need a lot of the clinical input, the imaging, the serum markers to actually make a definitive diagnosis of plasmablastic lymphoma. And then even, Zainab can attest to this, is that we've seen PBLs in immunocompetent individuals as well. So it does happen. I won't spend too much of time about this because Zainab and Jessica have done this much more with an in-depth glance. But just also important to remember that you can see elevated serum paraproteins. Okay, now in terms of diagnosis, it can be very complicated when you've got overlapping morphology and phenotype that can often resemble plasmablastic plasma cell myeloma with extramedullary involvement. And this is where it becomes really tricky. Like Jessica said, the MYC translocation is observed in at least about 50% of cases. Interestingly enough, it's the same translocation status as Burkitt lymphoma, except the difference being is that Burkitt lymphoma would have a B-cell marker profile, while PBLs will be negative for B-cell markers. However, their key indexes both approach 100%, which is very interesting. Like I mentioned, that EBV is positive in about 75% of cases, but it's also been reported that you can also get EBV positivity in myeloma, which clouds the waters even further. And the one thing that is important, like Jessica said, is the high key index, which would favor a PBL over a myeloma, and a c-MYC expression status that can be confirmed on the molecular platform as well. So in terms of the lab findings, we need to look for HIV status, we need to look at the CD4 counts, we look at the paraprotein levels, is there a monoclonal spike? And remember, we can access all of this information on our track system, which also helps us in terms of the AnatPath lab, put it together in a way that makes sense to the clinician as well. In terms of the prognostic factors, the MYC translocation status is often associated with a worse prognosis. Now, I just wanted to step away from the biopsy findings for a bit. I'm sure that many of the clinicians on the deep dive today are familiar with frozen section. And what it is that essentially we get a piece of fresh tissue from a lymph node, from an extranodal site, for instance, and we flash freeze it, and we actually put it under the microtome. So instead of the tissue being processed for 18 hours and then seen the next day, we can actually see it within 15 minutes and sort of give a differential of what we think this is. Is it representative of lymphoma? Is it TB? And I think that helps the clinicians quite a lot when it comes to making these very difficult decisions when there is SBC syndrome, for instance, and there's compromise. But what we've been told is that we should never make a diagnosis of plasmablastic lymphoma on a frozen section. And the reason for that is because you really require the adequate workup and definitive diagnosis with your immunopanel. It is impossible to make a morphological diagnosis because we must remember that aggressive B-cell lymphomas can often have plasmablastic, plasmacytic differentiation. Okay, now this is something that's really interesting. This patient actually, for some reason, had a FNAB, which is a fine needle aspirate. And what we saw on this was sheets of monomorphic cells with plasmacytic as well as immunoblastic morphology. Okay, and here are the large plasmacytoid cells. You've got abundant cytoplasm, eccentric nuclei, perinuclear palo and halo, and you've got lymphoglandular bodies in the background. Lymphoglandular bodies are basically cells that engulf lymphocytes in the background, right? And these are the plasmacytoid cells again with abundant granular cytoplasm. You've got extended cytoplasmic processes as well, and you can see the immunoblastic features here. Some of them are binucleate. And over here, it was just to highlight your tingible body macrophages, which are essentially macrophages that mop up the apoptotic debris in a very high-grade tumor, like plasmablastic lymphoma. And we've also got some abnormal mitotic figures. Okay, and then in terms of what we saw in histology, you see sheets of plasmablastic cells, large nuclei, macronucleolus. And the findings in terms of the immunopanel was very similar to what Jessica would have found. CD20 negative, CD38, 138 positive, T approaching 80, 90%, and EBA diffusely positive. Every single cell needs to be positive in a plasmablastic lymphoma. Otherwise, it becomes very tricky to decide, is this true plasmablastic lymphoma or is this a bystander effect of EBV in the background? Now, I just also want to just say that we had a very good opportunity to test out a different modality on this fine needle aspirate. So what we did is that we took the fluid, instead of smearing it on a slide, we took it, we converted it into a little pellet with a fixative gel, and then we created a histology slide that can enable us to run immunohistochemistry, EBA-ish, even do molecular like FISH. And so essentially what we could do is that we can give a provisional diagnosis based on a FNAB without asking the clinician to please go excise or biopsy the node. And in our case, we were quite lucky that we've got enough diagnostic material. We converted into a cell block and we ran an EBA on it, which actually did stain positive, as well as stained negative for CD20, positive for 138 and 38 and MUM1. So we were quite fortunate that we could make a call on the cytology, which actually is really helpful for the patient and clinician to streamline and triage patients immediately. I'm not going to spend too much time about the immunophenotype. Jessica has done that quite well. I just want to mention though that, CD30 and EMA can also be positive. CD56 can be positive in about a quarter of the cases. It can be diagnosed on flow cytometry, which we have access to, so that's also very important. In terms of the microscopic the description, I'm just going to go over this quickly. You can actually get a monomorphic appearing plasmablastic lymphoma as well as one with a plasmacytic differentiation. They see more frequently in HIV infection, in the oral, nasal, paranasal sinuses, and the important differential that was highlighted was the anaplastic plasmablastic plasma cell myeloma entity. That's a very important differential that needs to be ruled out. And so what you use is that you use imaging, you use your monoclonal serum peaks, your bone marrow sometimes may not always be involved by PBL, and then EBA-ish helps a lot as well. Okay, I'm not going to talk about molecular cytogenetics or the molecular aspect because Janique's going to do that, but I just wanted to mention that there are numerous translocations that have been detected, MYC being one of them. There's also some clonal rearrangements involving NRAS, Notch, and your STAT3. And there was some work done on the whole exome sequencing that identified these variant genomic aberrations that can be seen on the somatic side with plasmablastic lymphoma, and also with somatic copy number alterations seen in primary plasmablastic lymphoma. And the differential, again, is a diffuse large B-cell lymphoma with plasmablastic features, plasmablastic or anaplastic plasma cell myeloma, which Jessica very nicely gave good points, learner points in terms of identifying the difference between the two. Myeloma would also have CRAB associated with it as well. My important differential to raise in this one is the primary effusion lymphoma. I always run HHV8 in a plasmablastic lymphoma because you can never tell in a patient that is immunosuppressed with a low CD4 count whether you're dealing with a nodal primary effusion lymphoma. So that's what we've adopted in our lab as well. So we run HHV8 as well as EBV concurrently. And that's it for me. Sorry if I went over time.
Thank you, Darshini. That was perfect. You didn't go over time. That was really beautifully presented, very nice and clear. I'm not seeing any questions or comments in the chat. So I'm going to invite Dr. Janique Bailey to start sharing her screen. Janique is a hematology pathologist with us at the NHLS at Groote Schuur. She's been with us for 3 years. She did an undergraduate training in Bloemfontein and specialized at Wits. We're very happy to have her and to hear this presentation on the epidemiology and pathogenesis of PBL. Thank you, Janique. Go ahead.
Thank you very much, Jessica. Hi, everyone. Okay, let me just... Perfect. Okay, so I was tasked to talk about or present on the epidemiology and pathogenesis of plasmablastic lymphoma. So we'll start off with the, let me just, sorry, let's move some things around here. Okay. So we'll start off with the epidemiology. And I've included the findings of 2 local studies performed here at UCT. In the first, PBL comprised about 4.5% of 759 lymphomas diagnosed between 2005 and 2010, and 85% of these were HIV positive. Of 563 aggressive lymphomas diagnosed between 2012 and 2014, plasmablastic lymphoma comprised 6.5% of non-Hodgkin lymphomas and 50% of HIV-associated lymphomas. Okay, so plasmablastic lymphoma more commonly occurs in immunocompromised patients. So HIV is very important in our context. And a study published last year by the Wits team showed that there's no reduction in the frequency of plasmablastic lymphoma in the ART era, and this despite immune recovery and virological suppression. So other immunocompromised groups that's important to know of is the post-transplant group. This occurs in about 6% of plasmablastic lymphoma, as well as the elderly. In this instance, we're dealing with immune senescence, and a higher frequency of these patients are seen in a Western data set as compared to ours. This might be to a younger population here, as well as a higher frequency in HIV. There's a male predominance, about 3/4 or so of PBL patients are males, and this is seen in local and Western studies. And rarely plasmablastic lymphoma may evolve from a CLL or follicular lymphoma, and this is seen in 3% of cases, CLL more commonly than follicular lymphoma. So I've included the table from a study performed in the United States comparing the clinical and pathological differences in HIV positive and HIV negative patients. With the HIV positive group, comprising about 69% of the study population. Now, you remember from the previous slide that locally the HIV positive group comprised 85% of PBL seen. So in this study, there was a significantly younger age of diagnosis for the HIV positive group as compared to HIV negative, and a persistent male predominance, although slightly higher females seen in the HIV negative group, but this largely represented the elderly. So we'll move on to pathogenesis. So we'll first deal with EBV. So EBV is a double-stranded DNA virus of the gamma sap family. It's lymphotropic and undergoes lytic replication. Mainly affects B cells, although T cells and natural killer cells can be infected as well. 90% of the world's population is seropositive for EBV. 70% of PBL cases are EBV positive, with a higher frequency seen in HIV positive as compared to HIV negative plasmablastic lymphoma. There's no decrease in the ART era, and this is likely due to a number of factors, including immune evasion, chronic inflammation with an altered cytokine profile, immune senescence, which persists in people living with HIV despite ARVs and immunological or virological suppression. So in terms of EBV infection, the life cycle is divided into lytic and latent phase. Of the latent phase, we are 4 patterns can be seen, and the patterns of significance in PBL is the latency type 3, type 1, latency 3, and latency 0 and 1. So latency 0 and 1 seen in the majority of cases. But what's reported in terms of the latency type 3 is the HIV positive group as well as the post-transplant. So in the latency type 3, one would see expression of proteins associated with B cell transformation as well as proliferation. And this tends to trigger a very strong cytotoxic T cell response, in particular to IPNA3. Now, IPNA3 is a protein expressed by EBV. And majority of the infected cells will be eliminated. In the event where these cells are able to downregulate IPNA3 expression, only then will they be able to escape destruction. So that is if the patient is able to mount a sufficient immune response. And this might be problematic, or it's problematic in patients who are immunocompromised. In latency 2, what we see is expression of proteins associated with differentiation and occurs in the germinal center. And then latency 0 and 1 is associated with a marked downregulation of proteins expressed by EBV. And they're therefore able to escape detection by the immune system. All right. So in EBV positive plasmablastic lymphoma, immune senescence and evasion are in part related to the expression of PD-L1 by plasmablastic lymphoma cells, as well as tumor-associated macrophages, which prevent anti-tumor cellular responses. Additionally, there might also be a decrease in the expression or the absence in expression of MHC class 2 by EBV-infected lymphoma cells. As well as the secretion of IL-10, TGF-beta, and other suppressive mediators by tissue-associated macrophages and T-regulatory cells may further promote immune evasion. EBER is expressed in all latency stages, LMP1 and 2 only in latency 3 and latency 2. We therefore use EBER to identify or to show EBV infection on histology and not LMP1. Then just to point out that EBER as well as IPNA1, both of which express in latency 1 and 0, are anti-apoptotic. Actually, IPNA1 is not expressed in latency 0, sorry, but both are expressed in latency 1. As got anti-apoptotics function facilitates survival as well as immune evasion. And EBV results in added oncogenic mutations and tumorigenesis. The tumor cells end up with less dependence on EBV for their survival. So we'll move on to MYC. MYC is a proto-oncogene situated on chromosome 8q24. So MYC is involved in cellular metabolism, growth, proliferation, and apoptosis, and is normally expressed in B cells. So the expression in B cells are mediated by the B cell receptor as well as the CD40, which interacts with CD40 ligand or CD4 positive or T alpha cells, and is responsible for early germinal center reaction. So that would be cell cycle entry and proliferation. It's then in the germinal center suppressed by BCL6, and as the B cells exit the germinal center, MYC would then be suppressed by BLIMP1. So BLIMP1 is a transcription factor expressed by plasmablasts and plasma cells. It can also be mutated to plasmablastic lymphoma, and we'll have a look at that a little bit later. So MYC overexpression is seen in about 70% of plasmablastic lymphoma cases. This differs slightly depending on the source you use in the literature, but overall around 70%. And majority of the cases will be due to translocations, in particular translocation 814. So this is between MYC and the IgH promoter. Amplifications, they may co-occur, as well as secondary overexpression. So this might be due to an unrelated mutation causing MYC overexpression, for instance, STAT3. And we'll have a look at this later as well. Now, MYC mutations, so not translocational amplifications, mutations can be seen as a subgroup of plasmablastic lymphomas, but usually associated with rearrangements. So there's a important relationship that exists between EBV and MYC. So firstly, EBV causes MYC upregulation. So this is in particular latency 1 or latency 3, where EBNA2 causes MYC upregulation, resulting in proliferation of transformed B cells. MYC causes suppression of the EBV lytic program, meaning that it maintains the virus or B cell in a latent form and therefore mediates immune evasion. And then MYC-induced apoptosis, so this is seen with overexpression of MYC, is prevented by EBV, in particular EBNA 3A and 3C. And HIV positive PBL, there's an increased frequency of MYC overexpression and EBV positivity, and this has been mentioned previously. Okay. All right, so we'll move on to chromosome 1q21. So this is one of the copy number alterations, and there are a few others. But for the interest of time, I thought that I'll focus on this one because it occurs in about 43% of plasmablastic lymphoma. So what's seen here is an amplification of the gene that encodes MCL1. So MCL1 is a member of the BCL2 family. So it has an anti-apoptotic function, and it prevents, as is the case with BCL2, backs and back pore formation within the outer mitochondrial membrane and subsequent release of cytochrome C and activation of caspases. So upregulation is seen in numerous tumors, heme and non-heme. And what's quite exciting, although very early stages still, is the emergence of MCL1 selective inhibitors. So I've just added 2 articles here that deal with MCL1 inhibitors. Majority of the inhibitors are only entering phase 1 clinical trials, in particular for AML, MDS, diffuse large B, and plasma cell myeloma. So either as monotherapy or combination with venetoclax. But what was interesting, and this I took from a mouse study, and I didn't include the graphs because of time, but what this study showed, and once again this was a mouse study, is that the heterogeneous loss of MCL1, so that means MCL1, loss of MCL1 on one of the alleles, completely inhibits MYC-driven lymphomagenesis. So very promising target for therapy. Okay, so we'll move on to STAT3. So downstream from STAT3, interestingly enough, there's upregulation of MEK and cyclin D1, resulting in cell cycle entry, BCLX, which is anti-apoptotic, BEGF for angiogenesis, and then a lot of markers and solubles associated with immune suppression. Also very important for metastases. So this regulation is seen in numerous heme and non-heme tumors. And in particular, with regards to plasmablastic lymphoma, 42% shows STAT SH2 domain mutations, resulting in the constitutive activation of STAT3. And this independently causes MEK overexpression. Appears to occur more frequently in HIV-positive plasmablastic lymphoma. There are some other mutations in the JAK-STAT pathway as well, which we won't look at now. STAT3 inhibitors also entering phase 1 trials in AML, MPNs, and CLL. So there's some work being done there as well. Okay, we're moving on to PRDM1. So PRDM1 is the gene that encodes BLIMP1, and BLIMP1, as you remember, is very important for the suppression of MEK in plasmablasts and plasma cells. There's some mutations. So this would be missense mutations. It's seen in 50% of plasmablastic lymphoma, and appears to occur more frequently in EBV positive plasmablastic lymphoma. All right, some other findings. The other findings is the increased expression of CD44, which is important for growth and survival advantage. And then mutations have been detected in the ERK-MAP kinase pathway, may involve any of those, as well as the notch signaling pathways. This occurs in about 28 and 24% of PBL cases respectively. I'm not going to go into details here. Darshini also briefly referred to this. So just in summary, PBL is an aggressive but rare lymphoma. Very important is it occurs in immunocompromised individuals, HIV in our context, no reduction in the ART era. EBV positivity seen about 70% of cases, but high in HIV positive PBL. EBV inhibits anti-apoptotic proteins and promotes immune evasion. And then MEK overexpression seen in 70% of cases. It can be due to any of these reasons, usually in combination. And then STAT3 SH2 mutations, as well as amplifications of chromosome 1q21 is seen as well. And there are some exciting drugs entering clinical trials. That's it. Thank you very much.
Thank you, Janique. That was fantastic. I'm not seeing any additional questions in the chat. If there are no other questions for Janique or no questions for Janique, we're going to circle back to Zainab, who's going to speak to us very importantly about the therapeutic approach to these patients. Thank you very much, Zainab. Please go ahead and share your screen.
Thanks. Okay, so now we come to the crux of the matter. And when I agreed to speak, I told them I know I'm going to take a lot of flack for our undertreatment of plasmablastic lymphoma. So according to the NCCN guidelines, standard CHOP is not adequate therapy. We've been seeing this for years, and there are suggestions, EPOC, Codox, MIVAC, Hyper-CVAD. But if you go to the literature, there's really not much evidence that going more aggressive makes much of a difference. And we'll definitely argue this point afterwards, I'm sure. So just, there's really not much. This is an unusual lymphoma. It's almost an orphan disease. We see probably about less than 10 a year at Frisco Hospital. So I just went back to see what is there, what case series are there. So MD Anderson had a case series where most of their patients, 61 patients, but most of them were HIV negative. The 20 were HIV positive. And they found that those who got CHOP actually had a better overall survival than those that had Hyper-CVAD. And they found that age, stage, and EBV positivity were significant prognostic factors. And then someone looked at that same group, but teased out the stage 1 and 2 plasmablastic lymphomas, of whom 2 were HIV positive. And they found that using doxorubicin-based chemotherapy and involved site radiotherapy resulted in a 90% 2-year progression-free survival and 100% 2-year overall survival. So that brings in what people are seeing, in that these early stage disease patients are actually doing better. And then looking at this article by Chenong, where they looked at France and Belgium, the lysis centers, they found 135 patients with plasmablastic lymphoma, of whom 56 were HIV positive. And the median survival that they found for these were 32 months. But the HIV positive patients actually survived better than the HIV negative, which we've also seen with a few HIV negative patients we've had here. The complete response rate was the same for CHOP compared to the intensive chemo. And they found that IPI, use of chemotherapy, and complete response rate was associated with a survival benefit. Then the German AIDS-related lymphoma study had a few plasmablastic lymphomas in that study, 18 patients. They didn't do well at all, median survival of 14 months. And they found that an intermediate to high IPI was associated with lower overall survival, but their more intensive treatment protocols did not affect survival. And they were using BALL protocols. So far, I don't see any evidence that more intensive treatments actually help with plasmablastic lymphoma. Castile, who's really done a lot of work, he collected 248 cases from the literature, he analyzed them, 157 were HIV positive, and he found that prognosis was associated with a complete response, but there's no difference in survival with regimens that were more intensive than CHOP. And then we went on to collect 50 patients from 13 institutions and saw that the median overall survival was 11 months, regardless of the treatment they received. And then looking in the SEER data, they found that 57% of the patients in the SEER data were HIV positive, and those with an oral location of disease definitely had better outcomes. So just looking at plasmablastic lymphoma treated with CHOP, and there is a local study that was published earlier this year. In KZN, between 2006 and 2018, they had 26 HIV positive patients with plasmablastic lymphoma. Their 2-year overall survival is 42% using CHOP. And then recently, like this month, the British Columbia group published their 42 patients that they managed to collect over a 22-year period. 36% of them were HIV positive, and at a median follow-up of 8 years, the 5-year progression-free survival and overall survival were 18% and 22%, the median of 8 and 15 months respectively. So really not much better, in fact, probably worse than what we're getting in South Africa. So that's just talking about treatment. Now, I just want to look at what do we do for our patients, how do we stage them? And PET-CT is now the standard modality for staging and response assessment in FDG-avid lymphomas. There are definitely limitations, and everyone says, oh, we've got a lot of TB, what about that? But our nuclear medicine physicians are really good, and they know what TB looks like compared to disease. MRI is obviously indicated for certain anatomic areas like the brain, but it's definitely for me as a radiation oncologist, it's the best practice to be able to plan involved site radiotherapy. So there was a study published in the European Journal of Nuclear Medicine in 2018, where they took the LISA patients, 35 of them who had PET-CTs at diagnosis and at end of treatment. 40% were HIV positive. They found that all plasmablastic cases were FDG-avid with a median SUV max of 10 at the disease sites, and PET-CT upstaged 4 patients. So that's about 10% of the group, more than 10%. And they interpreted a Deauville score of 1 to 3 as having a complete metabolic response. Those with a complete metabolic response at end of treatment tended to have localized disease and low IPI scores. But if patients achieve a complete response after first-line therapy, there was significantly higher event-free and overall survival. So definitely PET-CT will be a useful tool for us in our management of plasmablastic lymphoma. And then prognosticating in plasmablastic lymphoma. So Hertel looked at the original IPI, the revised IPI, and the NCCN IPI to see which of these would be the best tool to use for plasmablastic lymphoma. And definitely the NCCN IPI is the most effective tool. And you can actually see there's a really good risk group there where one can easily tease them out from the rest who might need more intensive treatment. So yeah, it does seem to be the most useful tool for us to use. So the treatment basics is, I think we need to have use PET-CT for staging and for assessment of response. I think we should use the NCCN IPI. We can debate whether we'll use CHOP, hyper-CVAD versus EPOC, and I would love to hear from the other clinicians out there who are using the more intense treatments as to what they're seeing. I think CNS prophylaxis in high-risk cases is important. And what you do nowadays, it doesn't seem to really matter because it seems that intrathecal chemotherapy and high-dose methotrexate has the same outcomes. And whether you give high-dose methotrexate while you're on treatment, day 10 perhaps, or at the end of chemo, outcome is the same. In fact, they advise to give it at the end of chemo because it means less delays, and particularly with our HIV positive population, we see lots of cytopenias, so it might be easier to give the chemo first and then the high dose methotrexate. Remember, this is all studies in DLBCL. I mean, a lot of what we do for plasmablastic lymphoma is extrapolated from DLBCL studies. So interesting that a lot of there's always this debate, CNS prophylaxis, should we, shouldn't we, and what's the best? And there are quite a few studies that have come out recently looking at CNS prophylaxis within the past 2 years. One study showed that CNS prophylaxis actually, it's good, it delays CNS relapse, but they found that with longer follow-up, the CNS relapse in those patients where it's going to occur, it does occur. So maybe what we're doing is not good enough to prevent CNS relapse. There was one study, I think it was from Canada, where they felt that there's actually no benefit to using high-dose methotrexate prophylaxis. And then there was a very similar studies, but these are all retrospective. It's not large groups of patients. There was one from Pakistan and one from Finland. Both of them thought that maybe combining intrathecal and high-dose methotrexate would be the best way. So yeah, I feel that we should use CNS prophylaxis, and we can speak about what we think would be the easiest or the best to use. And then radiotherapy. Yes, I'm a radiation oncologist. I feel that radiotherapy for plasmablastic lymphoma early stage is very important. It's vitally important. We don't have a monoclonal antibody to improve outcome. We only have chemo, and you have localized disease, and particularly if it's bulky and generally it's extranodal and often head and neck involvement, there is evidence that with diffuse large B-cell lymphoma, adding radiotherapy improves outcome. So I think we can definitely extrapolate that to plasmablastic lymphoma, and I think you should really start investing in relationships with your radiation oncologists to help manage these early stage plasmablastic lymphomas to ensure long-term good outcomes. And then we mustn't forget, when we speak about treatment basics, to speak about palliation. Radiotherapy is good for palliation of big masses that are causing problems. And in fact, we've even had some patients survive longer than expected with palliative radiotherapy. And then chemotherapy, I don't know, maybe some of you can assist with what really is the best chemo to use for palliation. And then going further afield, bortezomib, I mean, this is a plasma cell type of lymphoma. Bortezomib, it sounds promising. Outcomes really do seem promising. There's this one study where this was a review where they looked at, and there were only very few, it's mostly cases, but they looked at all the cases and they found that the complete response rate when you combine bortezomib with dose-adjusted EPOC is 100%. And yeah, some of us get 100% with CHOP as well, or good responses with CHOP as well. And the 2-year overall survival is 50%. So it's not that amazing. They had, I think, about 8 patients, of whom 5 were HIV positive. So it's a really small group, but it's promising. And then what about stem cell transplant? So this is just looking at the ESPM data. They had data on 24 patients between 2001 and 2011. 7 were confirmed HIV positive. In fact, they only had information on HIV positivity in 8 out of the 24 patients. Anyway, 7 relapsed, so 2-year relapse rate was 30%. There were 3 non-relapse deaths, and the 2-year overall survival was 53%. But there was definitely much better outcome for those who had their stem cell transplant in complete remission. So I think that autologous stem cell transplant is something that is available to us. I know that resources are a problem, but maybe it is something that we can discuss for our patients with advanced plasmablastic lymphoma. And then Janique, in the article that is yet to be published, the review article, she just mentioned a few studies that are recruiting patients with plasmablastic lymphoma, and the top one is the most interesting one, daratumumab, anti-CD38. It would be really great to be able to get onto a study like that. So I just have a few thoughts and questions. So I feel that maybe we should consider stem cell transplant in first remission for high-risk patients with plasmablastic lymphoma, but we should use the NCCN IPI, as well as the other things that we consider when considering patients for stem cell transplant. And with obviously the HIV, it's whether they're compliant, it's social issues, all of that. Because they're going to join a queue with young children that you want to cure with your transplants. So yeah, but I think we should consider, because our numbers are really not that high, at least not yet. Fritzke, I don't know what everyone else is seeing. Then I'd like to know what people think the best salvage chemo is to use for relapse or refractory plasmablastic lymphoma, because we've tried ISHAP and DHAP and nothing really seems to work for these patients. And then I was just wondering, and I did ask a question about EBV positivity, because I get the impression that our EBV positivity is 100%. And is there any way, and I've seen studies maybe that we could perhaps use a plasma EBV DNA to prognosticate and to assess response. So yeah, I'd be interested to know what your thoughts are, and particularly those of you where money is not an issue, who may have used bortezomib for plasmablastic lymphoma, and just to know what your outcomes were. So thank you to everyone, especially the members of the multidisciplinary team, and of course our patients from whom we learn so much. Thank you so much. This is just inspiration for those that want to go to a live conference again one day. That's Lugano. Thank you.
Thank you, Zainab. I'm very fortunate. I'm going to a live conference overseas next week, so I'm very excited. That was very, very interesting. I see Estelle has her hand raised. Estelle?
Yeah. It was a good question about the EBV. And I saw that Jenny Vaughan was in the meeting. I don't know if she's still with us, but they have actually published last year their series and showed that, as others has also shown, I think, that the EBV is actually a bad prognosis. EBV negativity is bad. Jenny, you here? So actually in our setting, I would think that in your setting is very different than from ours. What do you say?
Hi, Estelle. Yes, we did find that. It was a little bit of a perplexing finding. It was in a small number of patients, so it has to be taken with some reserve. But our theory was that some of our patients who were EBV positive were not well controlled on antiretrovirals. And we thought possibly that immune reconstitution with antiretroviral therapy helped to control EBV as a driver of the lymphoma. So we thought that perhaps the antiretroviral component was helping us to target EBV in those patients. And those who were EBV negative didn't see that benefit from antiretroviral therapy. So that was our theory, but totally unproven.
That's very interesting. I don't know if there's more questions about, Zainab is going to say something, but I can also launch the poll. You must just tell me when, Zainab.
I just wanted to about the EBV. So if the ARVs are controlling the EBV, then you'd expect that, because most of our patients are now very compliant on the ARVs, that they would actually do well or do better. And maybe that outcomes will be better now that we've got better ARVs. Anyway, just throwing it out there.
Perhaps, but now we're diagnosing more because we, so I think it's difficult. Now, I must say in our institution, we definitely have a very strong treatment relationship with our radio. Zainab, I always have a problem with your job title, but Zainab always gives radiotherapy where necessary, and I'm going to now launch the poll. Is that okay, Jessica? Can I launch?
Absolutely. Go ahead, please.
Okay, so I quickly put this together. So it's really very haphazard, quick, and answer more than one. Answer those things that you've been using and that you believe in. And just while we're filling it in, I can just say that we have tried to...
I've seen my little Under Armour thingy.
Sorry?
You had it the end of it.
Oops. Okay. So, what did I? Oh, we have actually tried to get a few patients to stem cell transplant. And I think the difficult thing was actually they were very sick, but those who responded well, I think we've got two to transplant, and they did very, very well. So that's just from my side. And I'm going to end the poll. There's only a few treaters of plasmablast. Oh, no, people are still filling in. Let's see. I think we're done. Good. So 22 plasmablastic lymphoma treaters, and let's see what they have seen. Am I now sharing the results or not yet? Oh,
you're sharing, Estelle, yeah.
Great. So equal for CHOP and EPOC. We definitely don't go in for EPOC. And then very few people giving Burkitt-like treatment. By that, I mean anything quite intensive, also including hyper-CVAD. And then some people do combine it with rituximab. I don't think we do that, Zainab, or do we?
No, but I'd be interested to know what the rationale is to combine it with rituximab.
Yeah, I don't know. Is there anybody in the meeting who has looked into that? Because I think there is a bit of a rationale, but it's not always clear. Anybody who wants to speak up on using rituximab? Okay. So then, for example, to give you an idea, Prof. Patel's study at WITS, was countrywide. There you could actually give, as far as I remember, there was actually some discussion about giving rituximab or not. But yeah, typically you don't necessarily have a reason to give it, but it's not completely excluded. And then the RT, so very few of us actually have been able to send patients for RT, it seems. And then, yeah, also trying to get to stem cell transplant. Okay, thanks.
Thank you, Estelle. Very interesting. I think it's been a really great session. We're actually coming to the end, 26 minutes past 5, so everybody's stuck to time. I've really enjoyed the session. I hope that that everybody else has as well. I've certainly learned a lot, and I'd like to really thank Estelle for arranging this, Estelle and the team, and all the other presenters. And I think it's just such a great opportunity for us all to get together and learn together and think of ways of collaborating together. We have such amazing patients and such interesting diseases here. So thank you very much. And I'm going to say goodbye.
Thank you, Jessica and team. And thanks, Jacques, for your remark that we should all get some answers. So Jessica is going to chat about it at an international conference next week. And so we will continue talking about it. So everybody, great to have you with us. Have a good afternoon.
Thank you. Bye-bye.